HIV, AIDS. HIV is a retrovirus infecting the CD4 T helper cell. CD4 cells drop from a normal level of 600 to 1000 per microliter at a rate of 50 to 100 per year in a person who is untreated. Depletion of the CD4 cell count takes between 5 and 10 years before clinical manifestations generally occur. It is not HIV itself that leads to symptoms and death. Rather, the depletion of the CD4 count leads to opportunistic infections that lead to illness. Etiology: HIV is transmitted through injection drug use with contaminated needles, sex, particularly men who have sex with men, perinatal needle stick or blood-contaminated sharp instrument injury. HIV is transmitted through injection drug use with contaminated needles, sex, particularly men who have sex with men, perinatal needle stick or blood-contaminated sharp instrument injury. Kissing does not transmit HIV. Presentation: infections occur with profound immunosuppression when the CD4 count drops below 50 per microliter. PCP occurs at a CD4 below 200 per microliter or under 14%. When the CD4 count is above 200 per microliter, few infections occur. Infections at increased frequency with HIV but a CD4 above 200 per microliter are varicella zoster, shingles, herpes simplex tuberculosis, oral and vaginal candidiasis, bacterial pneumonia, Kaposi sarcoma. Diagnostic tests. The best initial test for HIV is the ELISA test. This is confirmed with Western blot testing. Infected infants are diagnosed with PCR or viral culture. ELISA testing is unreliable in infants because maternal HIV antibodies may be present for up to 6 months after delivery. Viral load testing, PCR-RNA level. Viral load testing is useful to measure response to therapy. Decreasing levels are good, detect treatment failure, rising levels are bad, diagnose HIV in babies. The goal of therapy is to drive down the viral load. Undetectable levels, below 20 per microliter, indicate that the CD4 will most likely rise. When the viral load is driven to undetectable levels and the CD4 rises, opportunistic infections rarely occur. Life expectancy for a person with HIV whose viral load is undetectable by PCR-RNA is equal in duration to an HIV-negative person. Viral resistance testing, genotyping. Viral resistance testing should be performed prior to initiating antiretroviral medications. This decreases the likelihood of starting medication to which the patient's virus is resistant. Resistance testing is also done if there is evidence of treatment failure. In the event of treatment failure, resistance testing guides the choice of medications to select 3 drugs from 2 different classes to which the patient's virus is susceptible. Treatment: any patient who is HIV positive and has detectable levels of the virus of PCR-RNA viral load testing is encouraged to start antiretroviral therapy, ART. This is true even if the CD4 level is normal. The mortality benefit is greatest with a low CD4 or T cell, T helper cell, level. Choice of initial therapy. The initial treatment of HIV is with 2 nucleoside reverse transcriptase inhibitors, NRTIs, and an integrase inhibitor. The integrase inhibitors are dolutegravir, elvitegravir, and raltegravir. Integrase inhibitors have both greater long-term viral suppression and allow incidence of adverse effects. Elvitegravir is used in combination with cobicistat, which increases its blood level. Integrase inhibitors are superior to both protease inhibitors and the non-nucleoside efavirenz. The preferred NRTIs for combination with the integrase inhibitor are tenofovir, alafenamide, and emtricitabine, abacavir, and lamivudine. NRTIs and adverse effects. You must test for the HLA-B5701 before using abacavir. Those with the HLA-B5701 mutation are at risk for life-threatening skin reactions such as Stevens-Johnson syndrome. Tenofovir has 2 different formulations. The disoproxil version of tenofovir is associated with RTA and bone demineralization. The alafenamide version is absorbed into the CD4 cell and has a lower plasma level. Because the alafenamide version has a lower plasma level, the incidence of adverse effects is lower. Treatment failure is detected by a rising viral load or failure of viral load to suppress to undetectable levels. CD4 count will decrease or fail to rise with a failing regimen, but changes in CD4 lag behind and are slower to occur than changes in viral load testing. Treating everyone, no matter how high the CD4 count, is encouraged. Ritonavir in a small dose is used to boost darunavir or atazanavir levels. Cobicistat inhibits elvitegravir metabolism, boosting its levels. Additional classes of second-line agents. These medications are used for those with drug resistance to multiple classes of first-line agents. Entry inhibitors, Infuvir Maraviroc. Post-exposure prophylaxis. Post-exposure prophylaxis is not routinely indicated for needle stick injury if the HIV status of the needle is unknown. All significant needle stick injuries and sexual exposures are given 4 weeks of therapy with combination therapy. The choice of therapy follows that described in choice of initial antiretroviral medication. Exposures to urine and stool are not an indication for post-exposure prophylaxis, PEP, unless blood is present in them. Bites from an HIV-positive person should initiate PEP. Abacavir hypersensitivity is predicted by HLA-B 5701 testing. Prevention of perinatal transmission. If the patient is HIV positive and already on antiretroviral medications that are effective at the time of pregnancy, the answer is just to continue the same regimen of treatment. The only exception is the use of efavirenz, which should be avoided in pregnancy because it is associated with teratogenicity in animals. Protease inhibitors are safe during pregnancy. If the pregnant woman has a high CD4, 500 or higher, treatment with combination antiretrovirals should still be given to prevent perinatal transmission. The baby should receive zidovudine during delivery, intrapartum, and for 6 weeks afterward to help prevent transmission. Caesarean delivery for HIV-positive mothers. Caesarean delivery is performed to prevent transmission of virus if the viral load is high. There is a special cutoff for what is considered an elevated viral load in pregnancy. If the viral load is above 1000 per microliter at the time of delivery, a caesarean delivery is performed. Most transmission from mother to child occurs during delivery. Make sure the viral load is controlled by the time of parturition. If the viral load is above 1000 microliters, perform caesarean delivery. Fully controlled HIV, viral load undetectable, gives less than 1% transmission. Intrapartum intravenous with zidovudine is routinely administered in every pregnant HIV-positive patient. Remember, pregnant HIV-positive persons should be treated with antiretrovirals during the whole pregnancy. Do not wait for the second trimester, and always use at least 3 drugs. Begin antiretroviral therapy even in the first trimester. The viral load and CD4 cell count have no bearing on the use of HIV antiretroviral medications in pregnancy. Antiretroviral medications are used in pregnancy, no matter how low the viral load or how high the CD4 count is. Use antiretroviral medications in pregnancy even if the viral load is undetectable. Pre-exposure prophylaxis, PrEP. Those who are uninfected with HIV can use medications to protect themselves from high-risk sexual and needle-sharing practices with potentially HIV-infected contacts. Pre-exposure prophylaxis means using emtricitabine tenofovir starting before the exposure to HIV and continuing for a month after the last exposure. If the HIV risk behavior is expected to continue, then the HIV uninfected person should continue the medications for the long term. PrEP stops a significant amount of transmission. Give the uninfected person emtricitabine tenofovir to prevent the acquisition of HIV.